biology and therapeutics. This is more crucial for your understanding because we have a new subset of clinical therapeutics from which questions are asked. So you may not be presented with direct questions in OPRA examination. The question may come in the form of a case, and then you have to diagnose it and then answer the question accordingly. So maybe you may not get a one-liner question with the introduction of clinical therapeutics in the portion. Now it's very important for you to understand the clinical and medical aspects of different diseases as well as their treatment approaches. Okay, so today we're going to start with a topic which is called as schizophrenia. We've often heard about schizophrenia as a term, but it's a very important topic in central nervous system and understanding the antipsychotic strategy. The idea of this masterclass is to give you an overview. It's to give you an overview as to how you should go about preparing topics and how to understand what kind of questions can come and how to go about answering them in the best possible way. And of course, after that, Shohini will be explaining about the entire format of the OPRA examination and certain other questions. So shall I begin, Shohini? Yes, great. As we all know that schizophrenia is the chronic heterogeneous syndrome of disorganized and bizarre thoughts. There would be delusions, hallucinations. So delusions are actually false belief of something which is not existing. So there have been patients who have come to my OPD in the psychiatry OPD saying that they feel somebody is poisoning them, they feel somebody is attacking them, whilst there's actually nobody. That's a false belief. So there could be bizarre thoughts, delusions, hallucinations related to the senses. Like there would be patients who can say they are listening to voices which actually don't exist. That's auditory hallucinations. Seeing things that are not actually present, visual hallucinations, inappropriate effects, laughing inappropriately at certain instances, talking bizarrely, that's called as inappropriate effects. Then cognitive defects in terms of their thought process and impaired psychosocial functioning, not being able to perform normally as per the societal norms. These are all the different features of schizophrenia. So in the OPRA examination, you might be given a question which mentions that so-so patient came with complaints of delusions, hallucinations, and how do we go about treatment of such a case? Instead of saying schizophrenia, you might be given to diagnose a case. So what are the symptoms of acute and post-acute psychotic episodes? As you know, schizophrenia, it's a form of psychosis. And the acute episode symptoms, these include hallucinations, like we discussed, hearing voices, seeing things, delusions, these are fixed false beliefs. Even if we tell them nobody is going to attack you, there's nobody who's around you, yet they will have that false belief that, yeah, somebody is plotting against me. Ideas of influence, beliefs of external control. They come up with a symptom that they are being controlled by an XYZ person who is not even existent. So these are some symptoms which occur in acute psychosis, in acute schizophrenia. There could be issues with thoughts and behavior, like disconnected thoughts, loose association, contradictory thoughts. One moment they feel something's really going right, and the very next moment they start saying, this is absurd, this is not in my favor. Withdrawn thinking, autism, like you must have seen autistic kids, you must have seen autistic individuals, how they are withdrawn from the normal world, they like to be alone. So this could also be a symptom of schizophrenia. Uncooperativeness, hostility or aggression, that could be either verbal or physical aggression. So all these are symptoms related to schizophrenia and also acute psychosis. Next slide, please. Emotionally, such a patient can be flat, inappropriate, or having labile effect. Labile effect means sudden changes in mood. Sudden changes in mood could be there. So what we'll do is we'll take up the questions towards the end of the presentation. Just allow me a few minutes, and towards the end of the presentation, we'll take up the questions. The patient could have impaired self-care, disturbed sleep and appetite, and residual features could be present after the acute episode. Emotionally and cognitively, the patient could be laid back. There could be anxiety, suspiciousness, poor insight, lack of volition, lack of motivation, not feeling like to do anything. Social and behavioral withdrawal, poor self care skills. There could be associated comorbid substance abuse as well. Such patients, they get addicted to certain drugs, certain substances. So, all in all, it is like a vicious cycle. A schizophrenic patient can initially present with mild symptoms, but if not treated well in time, and most importantly, if not detected well in time, it can get into a vicious cycle where the condition of the patient worsens, the patient gets emotionally and socially withdrawn, and ultimately even lands up into substance abuse. Next slide, please. Okay, let's look at the diagnostic criteria. You must have heard of the DSM criteria, which is Diagnostic and Statistical Manual of Mental Disorders. Previously, we had the fourth edition. Now, recently, we had the fifth edition of the DSM manual. And let's see what the DSM criteria says. If the patient has persistent dysfunction, the symptoms that we discussed already, they're all present lasting for more than 6 months. Definitely, it's a diagnosis of schizophrenia. If that's not the case, but at least two symptoms are present for 1 month or more than 1 month, such as hallucination, delusions, disorganized speech, grossly disorganized or catatonic behavior, or negative symptoms such as autism, social withdrawal, emotional withdrawal, depression. If at least two of these symptoms are present for more than a month, this would be a diagnosis of schizophrenia. There could also be markedly impaired functioning in work, social, or self care areas. Symptoms, as we discussed, they are classified based on the Diagnostic and Statistical Manual of Mental Disorders. Schizophrenia is one of the disorders that has been defined in DSM, but other disorders, other psychiatric mental disorders like post traumatic stress disorders, depression, all those have also been outlined in detail in the DSM. The positive symptoms in schizophrenia, these are delusions, fixed false beliefs, disorganized speech, hallucinations, disorganized behavior, abnormal behavior, sudden movements, that is catatonic behavior, and illusions. All these are positive symptoms. Negative symptoms referred to as alogia, poor speech, not able to talk properly, not able to present properly. Avolition, this means lack of motivation. Affective flattening, anhedonia, loss of pleasure. They don't feel pleasure in anything and just want to be by themselves and always depressed. And social withdrawal, all these are the negative symptoms. And cognitively, there could be impaired attention, working memory could be affected, and this could also affect their executive, that is, their functional movements and executive thinking and function. Next slide, please. All right, so let's look at the stepwise management. We can maybe zoom in the slide a little bit if possible. Yes, great. Yeah, let's go zoomed in. First episode, psychosis. So you can just hear me out also in case you don't want to see the slide. First episode, psychosis. When a schizophrenic patient first presents to a psychiatrist or to a doctor, what does the doctor do? Of course, pharmacological treatment is one aspect, and there's also non-pharmacological treatment in the form of CBT, which is cognitive behavioral therapy, where there is counseling sessions and also psychologist spends time with the patients to understand the issues and to allow them with some positive affirmations and some optimism. But then there is pharmacological aspect as well. Both go hand in hand. So pharmacologically, treatment-wise, we have to start with antipsychotic treatment. Can somebody name a few typical antipsychotics? First generation or typical antipsychotics. Can we have some responses in the chat box? Do you know examples of any typical or first generation antipsychotics? Yeah, there are quite a bit like haloperidol. Yes, flufenazine, correct? Okay, so I've just got flufenazine as one answer. Phenothiazine, very good. Haloperidol. chlorpromazine, thiaridazine, correct? What else? All right, so these are all examples of the common first generation or typical antipsychotics, but they have certain side effects which can be debilitating for the individual. So, what are the most common side effects which can happen with typical or first generation antipsychotics? What are some side effects that you can think of? Most common and debilitating one with first generation antipsychotics. Yes, anticholinergic side effects, motor symptoms, correct. Sedative will be seen with both typical as well as atypical. Yes, very well, Pooja, you answered it bang on point. I was looking for the word extra pyramidal symptoms. Yes, very good, Shweta, as well. Extra pyramidal symptoms is very, very specific to the first generation or the typical antipsychotics, okay, which can be debilitating for the individual. And why do these symptoms occur? It occurs because we are giving medications that reduce dopamine levels. We're giving dopamine antagonists. Ideally, in a case of schizophrenia, dopamine levels increase in certain areas of the brain, such as mesolimbic and striatal pathway, while dopamine levels will drop in the mesocortical pathway. If we give a dopamine antagonist like a first generation antipsychotic, it will not only decrease dopamine in the affected areas like mesolimbic and striatal pathway, which is responsible for positive symptoms of psychosis, but at the same time, it will also decrease dopamine levels in the mesocortical pathway and can lead to Parkinsonism like features like extrapyramidal symptoms, motor symptoms, all of which occurs due to first generation antipsychotics. These were the older antipsychotics, and that's why the newer second generation or atypical antipsychotics were developed, which don't have major extrapyramidal side effects, but they have some other form of side effects. So, what are some side effects that can happen with second generation or atypical antipsychotics? Yes. Metabolic side effects, absolutely correct, Mariam. Metabolic side effects can occur with first generation as well, but very prominently we see this with second generation antipsychotics. However, if we go to see clinically, it's easier to treat metabolic side effects than to treat the extrapyramidal side effects. That is the reason we use second generation antipsychotics nowadays in the first line. So you see this second generation, that is atypical antipsychotics, are preferred as a first line treatment, while first generation may also be used if the patient is not tolerating the second generation ones. But as the first choice, we prefer second generation antipsychotics. Okay, if a patient is not responding well to the SGA, then it's of course possible to use another second generation or use a first generation antipsychotic as a second stage, stage two. If a patient is still not responding to the different first generation or the second generation antipsychotics that were tried, then we have an option. Either we use a combination of first and second generation antipsychotic, or we add clozapine. Clozapine is specially reserved as a third line treatment in schizophrenia for the patients who have suicidal tendencies and who have comorbid substance abuse, because clozapine has a greater efficacy as compared to the other antipsychotics. However, it is kept as a reserve treatment in treatment resistant schizophrenia cases. Okay, so we have both options. If a patient is not responding to a single SGA or an FGA, we have an option either to use clozapine if there's a history of suicide or if there is a comorbid substance abuse. In case not, we can try a combination of a first generation and a second generation antipsychotic. Yet, if the patient is not responding, then we come to stage 4, where we combine clozapine, the more efficacious antipsychotic, along with an FGA, SGA, or an ECT, which is electroconvulsive or a shock therapy that is given to the patient. If the patient is still not responding, then use another SGA or FGA, which was never tried before. And of course, ECT has to be used in stage 5, which is electroconvulsive therapy. All right, so these were few things about the treatment with antipsychotics in a case of schizophrenia, and it's extremely important to monitor adherence in a patient. You might be given a question that the patient is taking the medications properly, everything is being tried, but yet the symptoms are not resolving. It is because of non-adherence. Because schizophrenia patients, they often lack insight. Insight means presence of mind. They don't even know that they're going through such a kind of disorder. That's why caregiver support and medication adherence is extremely crucial. And here, your role as a pharmacist becomes more important because a doctor may not have a lot of time to sit and counsel the patients how to take medications and why adherence is important. Likewise, to counsel the caregivers. So, your role in counseling and advising the patient and the caregiver becomes important, and that's why such kind of questions, clinical questions, are presented to you in the OPRA examination. Yeah, some examples of second generation antipsychotics that you can think about. Some examples of SGA or second generation antipsychotics. Type it in the chat box, please. Ziprasidone, very good. Quetiapine, yes. Olanzapine, okay. Risperidone, yes. Aripiprazole, very good. Yeah, most of it you've covered. The rest we will see in the remaining slides. Next slide, please. Okay, now remember we spoke that most of these medications, which are antipsychotics, they are mainly targeting as a dopamine antagonist to improve the positive symptoms. And they are also serotonin receptor antagonists, 5-HT2A receptor antagonists, mainly to treat the negative symptoms. So the first generation antipsychotics, they were mainly only dopamine antagonists, but the newer or the second generation antipsychotics, they have a mixed action. They also act as a serotonin receptor antagonist, which makes sure that the extrapyramidal symptoms are not prominent and at the same time the negative symptoms are treated. Antipsychotic medications, along with being dopamine and 5-HT antagonists, they can have antagonism at several other receptors, and that's why certain other side effects. Particularly if you go to see thioridazine, chlorpromazine, they have an anti-muscarinic or an anticholinergic action. Chlorpromazine also has an alpha-adrenergic receptor blocking action. Most of these antipsychotics, but particularly haloperidol, fluphenazine, thiotixine, all these are the typical ones. They definitely have a dopamine antagonist action, but it's seen more with haloperidol and the fluphenazine as well as thiotixine. That's why fluphenazine, haloperidol can be given as long-acting injectables, which have more efficacy and longer action, but more efficacy at the same time, more side effects, especially extrapyramidal. Then risperidone and clozapine also blocks the serotonin receptor, and particularly chlorpromazine as well as clozapine, these both, the two Cs, they also have some antihistaminic action at H1 receptor. That's why they have sedative properties. Next slide. Can we zoom it a little bit, please? Yes, great. Little bit. Can we zoom a little bit? Like around 120%? Yeah, good, good. This is good. So you look at the different antipsychotics. We have amisulpride, which can be given as a tablet or oral liquid. So amisulpride, aripiprazole, all these they come to treat acute psychosis. And amisulpride specifically, it's available as an oral liquid formulation as well, which makes it easier for a patient to take, especially those who have swallowing issues, who can't take tablet. For them, the oral liquid of amisulpride will be very, very effective. In acute psychosis, this atypical antipsychotic amisulpride, it's given in a dose of 200 to 400 milligram twice daily if given orally. And as a liquid formulation, also a similar dose of 100 milligram per ml. Okay, so we can give up to 2 to 4 ml, maximum up to 60 ml in a day. Aripiprazole, which is again an atypical antipsychotic, given as tablet, and it's one of those rare atypical antipsychotics which can be given as a long-acting injection. So you see, an injection of 300 or 400 milligrams can be given, which is long-acting and takes care of the symptoms for a few days. Orally, it can be given 10 to 15 milligram once daily, max up to 30 milligram. Then we have asenapine. We need not focus a lot on the brand names, but definitely understanding the scientific name and their properties as well as the dose will be important. Asenapine is given as a sublingual medication, which again makes it unique because asenapine is the only antipsychotic which is given sublingually at a dose of 5 to 10 milligram twice daily. Brexpiprazole, which can also be given 2 milligram escalated to 2 to 4 milligram daily, which is the maintenance dose. Then we have cariprazine. Start at a low dose, 1.5 milligram once daily, and slowly we can increase it up to 6 milligrams. Chlorpromazine that we spoke about, which is a typical antipsychotic, also available as an oral liquid, started at 25 to 50 milligram and then slowly escalated to 100 milligram 3 to 4 dailies max. Clozapine, also available as a tablet as well as liquid, started at 12.5 milligram and slowly escalated to 25 to 50 and 25 to 50 milligram further increments depending on the tolerance as well as the efficacy and symptoms of the patient. Clozapine, as we discussed, clozapine is reserved for which cases of schizophrenia? It's reserved for which cases of schizophrenia? Yes, can we have responses in the chat box, please? Yes, correct, Maria. I'm expecting others also to respond. So this is how we teach and learn, we have to keep it interactive. Only if you discuss, if you answer, you will be able to retain information in a better way so that you are well prepared for the OPRA examination. Not just reading, but it's important to recall and discuss. Yes, very good. For refractory cases or treatment-resistant schizophrenia cases, absolutely correct. Olanzapine is also one of our atypical antipsychotics, which is started at 5 mg, can be escalated slowly, available as an injection formulation as well, available as an oral disintegrating tablet as well. Next slide, please. Okay, then we have few other antipsychotics. At least the names you should know if you cannot remember the doses of all. The important ones I'll tell you which you should know. Droperidol, remember the name. It's just like haloperidol, typical one. Flupentixol, it's available as a long-acting injection. Pericetiazine, you may or may not remember, not very clinically relevant. Quetiapine is used clinically. So you need to know it's given at a dose of 25 milligram twice daily and can be escalated to about 100 to 150 milligram as the maintenance dose. Risperidone is also commonly used clinically. It's a long-acting, if given in injection formulation, and of course, generally we give it orally. Orally given at a dose of 1 milligram twice daily. Injectable is to be given in cases which are really severe and need immediate relief, in hospitalized patients suffering from psychosis, and also in patients who have swallowing difficulties or in elderly patients who cannot tolerate tablets well. Ziprasidone, also you need to know because it's also used clinically. Orally, 40 milligram twice daily is the dose. Zoclopentixol, given as an injection. Haloperidol, which is our typical antipsychotic, given at 1 to 5 milligram, 2 to 3 times daily, and lurasidone. So at least if you can't remember all, you need to know about olanzapine, which we discussed in the previous slide, quetiapine, risperidone, ziprasidone, and haloperidol, because all these are used very commonly clinically. Next slide, please. Then comes paliperidone. So paliperidone is one of those injectable antipsychotics which is very, very good in terms of its injectable preparation. It has a very long acting injectable preparations which are available as a monthly, 3 monthly, and 6 monthly injections. Okay, in which other circumstances will you prefer long acting injectables like paliperidone? Of course, when there is emergency in hospital, if the patient is old, swallowing difficulties, in which other situations will you prefer to use paliperidone long acting injectables? Very good. So I've got the correct answer from one student, that is Mariam. In patients who have a poor compliance, remember we saw about non-adherence in the flow chart. Non-adherence is a very, very, very common complaint in schizophrenia patients. So in such patients, using once monthly injection of paliperidone, 6 monthly injection, 3 monthly, that can play a pivotal role in schizophrenia treatment. Next slide, please. Okay, so let's look at management of treatment-resistant schizophrenia patients. If a patient is on clozapine therapy, in terms of effectiveness, only clozapine is a medication which has demonstrated superiority in clinical trials for treatment-resistant schizophrenia. It is very efficacious, but we keep it as a reserve therapy. First, we try to use the other medications. If the patient is not responding, then clozapine will be a reserve therapy in such situations, in such scenarios. Start with a 12.5 milligram test dose. If tolerated, as we discussed, increase it to doses of 25, 50, and even 100 mg. The maximum dose per day can be 300 milligram per day. We can expect an improvement in up to 6 months with about 60% of the patients showing progress, showing good progress. Okay. Now, in terms of augmentation and combination therapy, along with clozapine, we can add, or along with other antipsychotic, we can add a non-antipsychotic drug for poorly responsive patients, especially if they have certain other complaints like too much of violence, too much of aggression. Then, in those cases, we can prefer to add a benzodiazepine. Okay, so there's a rapid improvement which is common in responders, and discontinue the augmenting agent if no response, no improvement is seen. Combination therapy involves using two antipsychotics at the very same time, simultaneously. There have been clinical trials which have shown that 6 to 12 weeks, if taken for 6 to 12 weeks, such combination treatment may be attempted and it has shown good response. However, if beyond 12 weeks there's no response, then we can prefer to discontinue and try some other therapy. Next slide, please. Okay, in augmenting agents, we spoke about benzodiazepines. Certain other agents which can be added, these include lithium, valproic acid, and carbamazepine, especially for the labile effects. Remember, I told you about the mood changes, sudden depression and sudden elevation of the mood, very similar to the mood disorders. So that's why we can consider adding these mood stabilizers. We may also consider using divalproics combined with olanzapine or risperidone. So how is divalproics different? Is it the same as valproic acid or is it different? Okay, I want your response. Is it the same as valproic acid or is it different? Yeah, you should know what is unique about divalproics. Divalproics is actually a higher compound which is further broken down into valproic acid, but it has shown to have a better efficacy than valproic acid. It's a newer compound whose byproduct is valproic acid. It's a more active compound which is broken down into valproic acid as one of the components, and it has shown very, very good efficacy as a mood stabilizer. This is a recent therapy that is developed. In SSRIs, especially for depression, like negative symptoms in schizophrenia, we use selective serotonin reuptake inhibitors, SSRIs, antidepressants, which are used with FGAs to improve negative symptoms, because first generation antipsychotics, they have only dopamine antagonist property. They don't have serotonin antagonism. That's why they will not help with negative symptoms. Okay, so that's why with first generation, we have to combine an SSRI in most of the cases. Also effective for obsessive compulsive symptoms arising during clozapine treatment. Other strategies include combining FGAs and SGAs or different second generation antipsychotics. This has been explored, but we don't have exactly conclusive data. So one has to mix and match to understand which combination is best working for this patient. Next slide. Okay, now the adverse drug reactions of antipsychotic medications. Here we have an acronym called as seat belts. S stands for sedation, which is common with low potency first generation antipsychotics like chlorpromazine. Why it's common with chlorpromazine? I mentioned to you. Can you tell me why is sedation common with chlorpromazine? What is the major reason? Think logically, we covered it in one of the previous slides. See, like this, you will have to correlate it clinically and apply your knowledge because direct questions might not come. Yes, Maria, very true. It is because of the antihistaminic side effect, antihistamine receptor blockade, H1 receptor blockade, which we saw in one of the previous slides, that happens due to chlorpromazine. Some second generation antipsychotics like olanzapine can also cause sedation. Then we have extrapyramidal symptoms like dystonia, subnormal tone in the muscle, akathisia, Parkinsonism. These are all common with first generation antipsychotics, typical ones, the extrapyramidal symptoms. Yes, because of alpha 1 adrenergic blocking property, that's one of the reasons. And also because of excessive dopamine activity in the mesocortical pathway. Okay, so dopamine is not only reduced in mesolimbic and striatal pathway, but also in mesocortical pathway. That's why Parkinsonism-like features. Anticholinergic side effects like dry mouth, constipation, blurred vision, which is more common with low potency first generation antipsychotics and clozapine. Remember, we saw about antimuscarinic, anticholinergic side effects, the receptor blockage in one of the slides. T stands for tardive dyskinesias, which are late onset involuntary movements, more common with first generation antipsychotics. Blood dyscrasias, like changes in the blood parameters, such as agranulocytosis with clozapine. Abnormal agranulocyte counts, decrease in the WBC count, which can be seen with clozapine therapy. E stands for endocrine effects like hyperprolactinemia causing gynecomastia or amenorrhea, very, very common with second generation, especially olanzapine and risperidone. They cause good amount of hyperprolactinemia. Lipid abnormalities. Again, this comes as a metabolic side effect. Weight gain, hyperprolactinemia, gynecomastia, lipid abnormalities, all these are metabolic side effects occurring with second generation antipsychotics. Temperature dysregulation like neuroleptic malignant syndrome can occur with haloperidol and certain first generation antipsychotics, which is characterized by fever, rigidity, and altered mental status. Just to repeat, S for sedation, E for extrapyramidal side effects, A for anticholinergic effects, T for tardive dyskinesias, B for blood dyscrasias, E for endocrine effects, L for lipid abnormalities, and T for temperature dysregulation. This is the meaning of seatbelt. Next slide, please. Okay, so this is in short just telling you what we already discussed. It deals with the specific side effects like amisulpride. It is more of a atypical antipsychotic second generation, so it does not cause much of movement issues. It causes more of metabolic side effects, anticholinergic side effects, and hyperglycemia, prolactin increase, hyperprolactinemia to a great extent with amisulpride. Okay, when you see see haloperidol, sixth medication in the column. Haloperidol, majority of its effect is to do, side effect, it's to do with movement disorders like tardive dyskinesias and extrapyramidal side effects. Some of these medications have some specific side effects like amisulpride may prolong the QT interval. Chlorpromazine can have some photosensitivity. Clozapine can cause cardiotoxicity, cardiomyopathy, blood dyscrasias like agranulocytosis. Haloperidol may also prolong the QT interval. Paliperidone, what we saw in injection formulation, they can affect the libido. Similarly, with risperidone also we see the same thing. QT interval prolongation further with ziprasidone. Next slide, please. Okay, so let's come to test your knowledge. This is just an example or a representation of the questions that can be asked in the OPRA exam. So instead of asking you directly, you have a case. The case is a patient with schizophrenia. It started on olanzapine. What is a key counseling point for this patient? Please type your responses in the chat box. What would be a key counseling point for this patient? Very good. Yes. Yeah, so most of you have answered option B, which is indeed the correct answer. Check the glucose tolerance if the patient gains weight. Definitely, because there could be metabolic syndrome features and weight gain. Hyperglycemia is a major side effect of olanzapine. If you see option A has to be ruled out because weight loss is not expected. Rather, we expect a weight gain. So option A is out. Option C, absolutely incorrect. Antipsychotic medications are never taken SOS. Take the medication only when symptoms flare up. Incorrect. Take the medication on an empty stomach. Nothing of this sort exists. So the correct answer over here is going to be option B. Next slide, please. If we see this question, this is a different case. Some of the case scenarios might have longer sentences, so you should be well prepared to deal with such longer sentences, which you have to read, understand, and then come to the question. A 25-year-old male with schizophrenia is prescribed risperidone, an atypical antipsychotic, to manage his negative symptoms, including delusions as well as hallucination. So, along with negative symptoms, this patient is having delusion and hallucination, which are positive symptoms. He is also experiencing some side effects after a few weeks of treatment. Which of the following is most commonly associated with risperidone? Yeah, most of you have answered correctly. It is option C, hyperprolactinemia. Remember, I told you hyperprolactinemia very common with risperidone, with amisulpride as well, and can occur with olanzapine too. Most of these second generation or the newer antipsychotics cause metabolic syndrome, metabolic features, one of which is hyperprolactinemia. Next slide. Read this question. It's a 55-year-old male with schizophrenia who has been stabilized on olanzapine for 6 months. His recent lab results, they show increased blood glucose levels and elevated cholesterol. What is the most likely cause of these metabolic changes? Now, this question is a little easy because the first option is self-explanatory. Olanzapine-induced metabolic syndrome. But supposing olanzapine-induced metabolic syndrome was not mentioned and only metabolic syndrome was mentioned, then also you should have come to the correct answer, which is option A. Type 2 diabetes is also a possibility, but here we have to choose the best option. So the most likely cause is option A, which is olanzapine-induced metabolic syndrome. Diabetes may also be induced with atypical or second generation antipsychotics, but given the options, the best option is option A. Next question. Next slide, please. Okay, read this question by yourself and tell me what should be the answer. You should have a habit of reading questions by yourself as well. Which intervention could improve medication adherence and symptom control? Patient is non-compliant. Frequent relapses. Yes, option A is the correct answer. Start a long-acting injectable antipsychotic as we discussed. If a patient is non-adherence, then the best thing to will be to add a long-acting injectable antipsychotics. Some of which we discussed, like amisulpride, can be given by injection route. Risperidone can be given. Paliperidone. All these are the atypical or second generation antipsychotics which are given by the long-acting injectable route. Next slide. A 65-year-old female on long-term haloperidol therapy for schizophrenia develops involuntary symptoms, movements, including facial grimacing and tongue protrusion. So what is this condition called? These symptoms, what is this condition called as? First, let's understand what is the condition, and then let's understand the question. So to be specific, yeah, this can be called as dyskinesias. You can say it's tardive dyskinesia, what we discussed. TD, tardive dyskinesia. These are all features of tardive dyskinesia, and the most appropriate next step in managing her symptoms, it is going to be option B, switch to a second generation antipsychotic. Option B. Option D is also not incorrect, but here we have to choose the best possible option. Okay, the best thing, since the patient is already developing drastic symptoms, now it's time to stop the haloperidol and start with a second generation antipsychotic. Can be given by injectable route or oral, whatever suits the patient. Next slide, please. So this is your answer key. You can always test your knowledge, have more discussions, and rely more on case-based Q&A kind of questions. Yeah. So next slide. I think Shohini, this is the end of the presentation.
Right, ma'am. Thank you for the guidance.
Yes. In case questions, if you would like me to take up or anybody from the team.
Sure. I'll talk about this, but before that, if you guys have any question regarding the topic, please feel free to ask them. You can just raise your hand and they might be able to call you your name.
Yes, Isa, go ahead.
You can unmute yourself. Try unmuting once. Shoaib.
Or they can type the question in the chat box. Chat box. You can use the chat box option.
Hello, can you hear me?
Yeah,
Hello?
please go ahead.
Yes.
Okay, yeah. With regards to the last question about the side effect of haloperidol, what I used to know is once that side effect starts setting in, and an anticholinergic is promptly instituted. I'm not sure whether clinicians are quickly going to switch to second generation antipsychotic based on majorly costs in
yeah
in the local environment.
Correct. So
That
this
would be the
is
confusion.
definitely, indeed, this is a very good question. So when I was working in psychiatry or OPD, and I'll tell you clinically also what happens is, we do try to give anticholinergics like benztropine and tardive dyskinesias in the initial stages. But at this point, the patient has been taking haloperidol for a long period of time. And since it's gone into facial grimacing and tongue protrusion, the symptoms have further expanded. It's not just dyskinesias or involuntary movement. There is also facial grimacing that is involved and tongue protrusion. Tongue protrusion can be extremely debilitating for such an individual. So that's why in this case, we will prefer to switch to a second generation antipsychotic. That being said, there is one more option. We switch to a second generation antipsychotic and we can still continue with lower doses of haloperidol, but with minimal doses rather than higher doses. So that way, in the initial, that is a transition phase when we are switching and adding on a second generation and lowering the dose of the typical antipsychotic or haloperidol until the patient has, become uh, kind of used to the second generation or the atypical antipsychotic and is responding well to it. So what you're saying is right, but given the intensity of the symptoms, we prefer to switch or add a second generation antipsychotic and lower the dose of haloperidol Starting an anticholinergic drug like benztropine is also definitely an option. We do use anticholinergics to reverse these kind of tardive dyskinesias and dyskinesia symptoms. But since facial grimacing and tongue protrusion is an add-on symptom, not just abnormal movements, there are certain facial and movement involvement. That's why a better option will be option B.
Okay, thank you.
Okay. Yes.
Ma'am, there is a query on the chat window. If you can just check, it is from Samson.
Sure. Some second generation, like risperidone, blocks dopamine. Yes, so most of the second generation, in fact, all of the second generation and the antipsychotics, they do block dopamine. They are dopamine antagonists, but they don't block the dopamine in the mesocortical pathway. They block dopamine in the mesolimbic and striatal pathway. The mesocortical pathway is responsible for bringing about the extrapyramidal symptoms. And that's why we don't see much of these extrapyramidal symptoms with risperidone or other second generation antipsychotics which are used. Rather, we see it with the first generation antipsychotics. Yeah, so Mariam's question, do we need to taper down the dose first or we can withdraw it abruptly? So the best thing would be to taper down the dose and simultaneously add a newer antipsychotic with it. Okay, but if that option is not given, then you can choose switch to. If that option of tapering down and adding on another antipsychotic is given, that would be a better option. It's always best to taper down and then stop rather than withdrawing it abruptly. Yes.
Okay. Any other question, guys, from this particular topic or any doubt you would like to ask? Guys, any question? Please let us know. Anyone, any question?
Yeah, in case you still come up with some questions, you can tell us in the due course. Maybe Shohini, you would want to take it up.
Yeah. So just wanted to highlight that we have come up with another, flag under our umbrella, that is Educapit. So this is the QR code that is given. Please scan and join the group. It will help you to get updated regarding the latest update about the study abroad programs, or if there is any update regarding your visas, it will be helpful for you. So you can join our channel. I'll be holding it for a few seconds. If you have not yet done it, you can join that. Followed by, this is the WhatsApp channel of ours, wherein we post regular updates about the OPRA examination. If there is any, frequently asked question that we get to see, surely we, share you the latest updates, so you can join that too. And we are also opened our new experience center in Hyderabad. If you are nearby to this particular location or would like to meet one of our team members or our team, please visit there. So you can just have a screenshot of the location. If you are not yet aware about the new experience center, you can surely meet us. Okay. Now, given we have come to the end of the presentation, if you have any question still regarding the OPRA examination, please feel free to ask them. Any question regarding the topic, we will be happy to take it. Any question, anyone, maybe a thumbs up if all good from your end would surely give us a confirmation. How's the session, guys? Did you guys like it? Or helped you with a quick revision? Great, great. Ashish, we are surely trying to do that. as you can see, like over the weekends, this is more preferable, right? So whenever you get to see such updates coming up in our channel, that's why I was telling you that please join our channel, because we keep posting about it. So you can join us surely. What is the next step after registration? Are you talking about the after registration, Mariam?
Ma'am, I'm asking, like after registration, uh, do we need to collect the admit card, or will the exam centers will be posted on the APC website? Like, how are we supposed to know that
They will be
how at
directly
what time and
emailing.
venue?
So basically, what you do when you are booking the examination, right, or examination dates, because this particular examination will get conducted for the 3 consecutive days, right? And given that, when you log into your APC portal, you can directly select up the particular date that you wanted to sit for it. Also, the location will be mentioned there. So you can just book that particular slot, particular date, and once you're done with the payment of your examination booking fees is done, we will be emailing you with a confirmation. Also, before the examination, for say you are appearing in July or July 14th, right? So before 2 or 3 days, we will be getting a complete confirmation email from their end. Also, they will ask you to carry some documents for verification. So that is the process, Maria.
So they will completely guide us after the registration.
Right. Also, they will
Ma'am,
guide.
one more thing, like I'm asking, for example, if you are abroad, right? So if your document, for example, your license, your Indian license, pharmacy license, it's also necessary to be taken with you at for the exam, or just only passport is enough for
Pharmacy
you?
license is not required, but surely your passport, that is one of the mandatory
Yeah.
documents I would suggest you to carry. That is one thing.
Mhm.
Other than that, if you are deciding outside India, right? So in that case, any credit card or debit card wherein your name is embossed, right? That
Yep.
also you
Yep.
can carry. Yeah,
Yep.
along with the PL. Okay. Also,
Yep.
those appearing from India for the Aadhaar card, try to take the new version or the new digital printed Aadhaar card with you. However, from our end, before the examination, if you are already part of Academically, you will be guided in detail how to prepare for the last minute and what all documents are required to carry. You will be given guidance for that too. So not to worry. Now, this is the time I think you all should focus on the preparation. We still have like good amount of time in hand. Practice then. Yeah, I will surely show you QR codes once again. So this is for our official channel. You guys can scan and join it. And this is the study abroad. Also, you guys can, subscribe us on our YouTube channels as well as on the Instagram page for the latest updates. I could see the message pop up, but it is not visible at my end. Okay, now it is coming up. Once again, let me just check it. Joishi, recent batch updates. We just started with a batch, and there will be few more batches in line for the upcoming months. You can check with our team directly, or maybe if you are interested, one of our team members can get in touch with you, and we'll be able to guide you. Tenzin, ma'am, do you also help with the internship guidance and visa counseling after this? Yes, we do that. We do provide the basic guidance so that you guys are well aware about the steps or the required documents to be collected and everything. So that will be done from our end. So these lectures are specifically for our, YouTube channels. You can always refer to such recordings here. And if you would like to revise it, you can do that. Samson, if I am not wrong, you're part of OPRA 3, right? So in that case, that batch will be over in June 15th, including the revision and everything. So stay updated on the Discord platform. Any other question? Any other question, folks, or else we are good to wrap up for the day. As of now, that is the only way you can join through QR code. Or maybe you can follow us on Instagram or YouTube. That will also serve the purpose. This class got recorded already, will be uploaded on our YouTube channel. You can review that. Okay, thank you so much everyone for joining. Thank you, Nishna ma'am, for the wonderful session.
Thank you, everybody.
Practice so well. Good night.
Thank you. Good night. Take care, everybody, and hope you read well. And all the best. Thank you.
All the best. Thank you, ma'am.